We're going to shift gears completely here, and we're going to talk about something that's much more clinically relevant to your practice on a sort of day-to-day basis, and that is ketamine. So I hope that was the correct schedule. There's been some flopping around of the speakers, and I know everybody hates that, but I believe that we're on the correct schedule now, which is ketamine, even more uses, and that's what we'll be talking about for the next 27 minutes. I've got my alarm so that we can try to keep it on pace so that everybody can get out of here and enjoy the nice weather at the end of the day. All right, so let's start with just some basics about ketamine. How many of you routinely use ketamine in your emergency department? Great, I love it. 5 years ago, that was a much smaller number. How many of you routinely use it for adult patients in your emergency department? Great, 5 years ago, that was an almost zero number. So this is really good that we're seeing the use of ketamine. Ketamine is a beautiful drug. It's a dissociative agent. It has a chemical structure that's like PCP. It's an NMDA antagonist, in case of any of you have to recertify on your boards or anything. I always have to check every time, is it an antagonist or agonist? Because I have no idea what NMDA receptors do in general, other than if you block them with ketamine, apparently you have a dissociative reaction. So that's what they do. Their primary role traditionally in medicine has been for the induction and maintenance of general anesthesia. But for emergency medicine, I think it's pretty obvious that ketamine's primary role has been for procedural sedation, okay, where it has wonderful characteristics that include a lack of respiratory depression and the maintenance of pharyngeal tone. Right? So people, you give them a big dose, a whopping dose. It's almost impossible to overdose someone on ketamine. Give them a whopping dose of ketamine and they breathe right through it. So that's beautiful for procedural sedation. And as we've gotten more accustomed to its safety profile, initially we used a lot in kids and we worried a lot about emergence phenomena. We've gotten more and more used to it. We start to see its relative benefit to adults. We're starting to ask ourselves questions about what else can we use this wonder drug for? And I should stop and say I have no tie to the pharmaceutical manufacturer of ketamine, which is some bizarre New Jersey pharmaceutical company that I don't think you can own stock in. Anyway, but people now, because of the familiarity with the drug, its excellent safety profile, are starting to ask ourselves, are there any other ways we can use this drug that can be helpful, because it has interesting alternative biologic properties, right? Two of those that we'll be focusing on this chapter are it has bronchodilation. That's been a well-known fact of ketamine. And the other one is that it's an analgesic, right? Unlike some of the other agents we use for procedural sedation, such as a Versed, right? Someone comes in severe pain with Versed, you give them Versed, they might stop crying as much, but it has no effect on their pain levels. So we're going to spend most of the time in this chapter talking about ketamine as an analgesic. Then we'll talk a bit about it in terms of its bronchodilatory effects and whether that has some clinical utility. And then we'll finish off the chapter talking about a few side effects and how to manage them in ketamine. So that was my preamble. Let's dive in. Number one. So the first 4 or 5 abstracts, I would say, basically go down to can be summarized as this: using ketamine for analgesia in really difficult patients, right? So most of the time, and I don't want Jerry to come and jump down my throat and say, you should just be giving more morphine, more morphine, more morphine. In general, that's how we should treat severe acute pain, morphine. It's not complicated. However, there are occasional patients where morphine makes us skittish, right? And number one is not really emergency medicine, but this would be a prototype patient. This is a randomized controlled trial of patients who have just undergone thoracotomy. Right? They're in the recovery room, they're in severe pain because they've just had their chest ripped open and coronary arteries sewn back together, etc. And giving them morphine, they're already splinting, they're not breathing well, etc. Giving them morphine might induce a level of respiratory depression that could require reintubation. This is a common problem in the CTI, cardiothoracic ICU. So this is an RCT putting people on the standard morphine PCA versus a lower dose morphine PCA that's supplemented with ketamine. Okay, and the doses there, just for our understanding, are 1.5 milligrams of morphine in the PCA with every 6 minutes click out, and then 1 milligram of morphine in the other one, and a very small dose of ketamine, 5 milligrams. So this is a subdissociative dose, right? This ends up being less than 0.1 per kilo. And remember, the dissociative dose of ketamine is typically about 1 per kilo, maybe 0.5, but certainly at about 1 per kilo. And 0.1, 0.2, those are subdissociative doses. You're not going to have people go into la-la land at this. So they give them these things, they randomize them, and what do they find? They find, it's a small trial, but the results are very, very positive. Overall, there were many, many fewer activations in the group that had the morphine plus the small dose of ketamine. Okay, so even though it's a smaller dose of morphine, they only had 28 activations in that group versus 66 in the other group. Okay, 2 of the patients in the morphine group had to be reintubated, none in the ketamine group. Obviously, very, very tiny numbers, not something that we should, think is serious evidence, but nonetheless, everything kind of pointing in the right direction. One interesting feature of this was that the pain was actually rated higher in the ketamine group. So the patients still experienced a little bit higher pain, but they didn't click the button as much. So I'm not sure exactly how to interpret that, but overall, this is pretty good evidence that ketamine can be used. It results in less activation, and the pains remained mostly in the moderate zone anyway. So I think this is good. This is a really difficult patient population to deal with, and then we'll see in the next few abstracts that ketamine has probably some value in the kinds of really difficult patients that we see a lot in the emergency department. So the next one is use of low-dose ketamine infusion for PEDS patients with sickle cell disease. So this is a little bit of a special population. Again, a little bit different than exactly what we see, but this is a challenging patient population. These are patients typically that are very opioid tolerant and dependent, where escalating doses of opioids seem to have minimal effect on the overall pain situation. And yet, the patient's continuing to complain of 10 out of 10 pain. You're getting to doses that are making the nurses and everybody start to get skittish. They're starting to say, you can't even send somebody to the floor with that level of pain. That's an ICU thing if they're on that level of morphine, et cetera. And so this is just a brief case series, I think, of 5 children who are already on PCA and in continuous infusions of morphine, and then in an effort to switch them off and get them to be able to leave the hospital, they switched them over to a sub-dissociative dose of ketamine, 0.2 per kilo per hour. And the results, again, 5 kids, not big science here, but 5 kids, and the authors overall say that we liked it. They say that 2 out of the 5 had a great response to the pain, got a lot better. One out of the 5 didn't have a dramatic response in pain, but they were able to titrate the morphine down, and that helped the management. And then 2 of the 5 in this particular case had a little bit of dysphoria. So that starts to bring in this question. Even in sub-dissociative doses, we do see people start to have some of these side effects of ketamine. So here again, we see a little bit of evidence to support the use of ketamine, even in people who have really, really severe, difficult to control pain syndromes. And I should just emphasize, these were kids with sickle disease who weren't just in the ER for a pain crisis. I mean, they had been admitted to the hospital. These are really difficult, refractory patients to take care of. The next one is the same kind of concept, but this is just really a really difficult one, and this is getting closer and closer to what we treat in the emergency department. It's the use of ketamine in severe cases of refractory pain. It says palliative care setting, but these aren't people who are what we usually think of as palliative care. These are patients who had severe pain syndromes due to neuropathy, inflammatory conditions, and opioid-induced hyperalgesia. So this is like the most challenging case probably that we get into. And here again, they reported that this is 4 cases. 3 of the 4 had a good response immediately after switching over to ketamine. And so the authors conclude that this is a really, viable adjunct. Again, not evidence, not a randomized controlled trial, but when you're up against the wall with somebody who you're infusing large amounts of morphine, and maybe this is something that we can reach for. Abstract number 4 is the first one that actually applies this in the emergency department. This is out of New Mexico. And it's a much larger case series still. It's not, again, not science, not RCTs, but it's 35 patients in New Mexico, each of them getting sub-dissociative doses of ketamine, so less than 0.5 milligrams per kilogram. It's a 2-year study, and we have no idea why they selected some people and didn't select others. Okay, but the patients that they selected tended to be the kind that maybe I would think you'll have trouble controlling their pain. They were almost all chronic opioid users. Many of them were IDU, et cetera, injection drug users, et cetera. So what did they find in this case? They gave this 35 people these sub-dissociative doses of ketamine. About 50% had an apparent improvement indicated by an immediate 3-point drop in their visual analog scale for pain. So that's comparable to the usual response to a 0.1 per kilo dose of morphine. All right, but these are patients who were fairly refractory to the morphine. So they gave them the ketamine and they had a nice drop in their pain score. That's only half of them. 25% of them had no appreciable response, and then the other 25% was somewhere in between, and the methods don't allow for very, very clear understanding of what happened here. So, we don't really understand exactly how this fits together, but there's evidence, at least, that in all of these kinds of difficult cases, ketamine might have a little bit of a role. In all of these cases, and including the emergency department study, almost all the ketamine was given IV. And I don't know if you can give IV at your institution, give IV ketamine at your institution without, filling out the 150,000 papers, even though you're giving a subdissociative dose and it's not for procedural sedation, it's for analgesia. So this might not be ready for prime time at your institution tomorrow to start pushing this stuff, but there's a growing body of evidence that ketamine may have a role, particularly for these very difficult cases that are otherwise, just such a challenge for us. I would say that, the next question in the section is, I think, really part of the same question. It says, does it have a role in palliative care? And it's really just another example of a terrifically difficult case where ketamine's helped. This is a case report. It's abstract number 5. It's a case report of an elderly woman who I believe got a dose of Levaquin and developed angioedema. She was DNR, DNI. This is actually a case report from a friend of mine, and she had this apparently very substantial angioedema that they didn't think was actually going to kill her. They thought that it would probably arrest and get better with treatment, but she was really laboring. Under normal circumstances, they would have intubated her, but she was a DNI kind of situation. So the question became, how do we manage this woman who's suffering, but we can't really, do RSI and all that kind of stuff with. And the family didn't want that, and there were no guarantees they'd ever be able to wean her off the vent and all these things. And according to my friend, she had some pulmonary problems, so there was very serious concerns about putting her on a vent and whether that would, just lead to 6 weeks of, ICU level care. So what they decided to do was give ketamine. To have her dissociate. It'll make her anxiety lessen, and they can wait for the epi and the steroids and stuff to work on the angioedema. It's a case report. What are you going to do? But it worked. It got them through it. And so again, just something to consider when you're having difficulty and you have a patient who's anxious, and either they're refractory to other opioids or other medications that you would usually use to treat pain or potentially anxiety. But you can't do that, so maybe consider a subdissociative dose of ketamine if you can do it, swing it at your institution. There's been, it's not included in the abstract, but there have been 2 recent trials of this published out of Australia. I'll go over one just really briefly. It's intranasal ketamine for limb injury in children in the emergency department. There's a pilot study by Dr. Yeaman. Does anyone know Dr. Yeaman in Australia? I don't know. And so what they did in this particular case is they took regular kids. So this is no longer the difficult patient population. They're saying, well, it works in difficult patient populations. Maybe it'll work in other patient populations. And what they only had 30 kids, but they gave them ketamine intranasally via a mucosal atomizer device. Have you ever seen one of these things? It's essentially, a little tip that goes on the edge of a syringe. You squirt fluid through it. It atomizes it, gets into the nares. And they reported these kids generally had broken arms and such. They report that that about 80% of them had a dramatic decline in their pain scores. So they were able to do this really quick without an IV, and they report good results from it. They did note that, so it was 83% of them were satisfied with their pain management. The visual analog score dropped from 74 to 30 at 30 minutes, so a very nice decline in the pain score. They did note that 14% of them had some dysphoric reaction. Now, it's not compared to morphine, and some people get dysphoric reactions to morphine, but it does sort of raise the specter that if you give this intranasal stuff, there is some cost, or if you give ketamine in general for analgesic doses, there's some cost, and some of the kids don't like it very much, and that's where some of the satisfaction declines came from. So again, not quite ready for prime time, but something to know that ketamine is out there. It could be used for analgesia in very severe cases, and there's increasing evidence that it might be able to be used for more routine cases. The next section talks about its use in the pre-hospital setting. Right? Again, we know that the safety profile of this drug is excellent, so can it be used in more austere environments? And I think this is relevant for us for lots of reasons. One, many of us operate base stations and direct ambulances. 2, some of us are actual EMS directors, et cetera. And 3, all of us are going to be receiving pre-hospital care transfers. So we should know that this is starting to gain some traction in the pre-hospital literature. So abstracts 6, 7, 8 are sort of related to this. Number 6 is a British article of 164 very severely injured trauma patients and their children. About half of them were MVAs. 23% of them were burns, and they got ketamine in the field. So it varied between subdissociative and dissociative doses, mostly subdissociative, and they said that everything was great. This was a safety trial. They were looking for evidence of the kids having loss of pharyngeal muscle tone, things like that, apnea, et cetera, and they didn't observe all of this. And of course, this should be noted, this is British. Most of the ketamine delivered here was delivered by doctors, not by EMS agents or paramedics, so they probably selected it well, and they were able to handle any complications a little easier. But it's beginning to build the evidence that this is a safe drug to use in the field. Abstract, I'm going to skip 7 for a hot second, we'll get back to it. Abstract number 8 is the same kind of concept. It's a systematic review of all the pre-hospital studies in this, and they found 6 studies, 340 trauma patients, 2 of them were RCTs, one of them was good quality, so mostly not great quality evidence, but they found that ketamine in the summary of this was effective and safe in the pre-hospital setting, which then brought us to abstract number 7, which is kind of cool. This is pretty new abstract, and it's ketamine and morphine is superior to morphine alone for out-of-hospital trauma. So again, one of these situations where increasingly for difficult cases, we see that it's effective. What about for the more routine case? And what they did here is they had 135 adults, all of whom had trauma and a pain score of greater than 5, and they randomized them to getting 5 milligrams of morphine and then subsequent doses of either morphine or ketamine. So everybody got 5 milligrams of morphine in the field, and then after that they got 5 milligrams more morphine or 10 milligrams of ketamine. So that's a subdissociative dose of ketamine. And there's some interesting findings that happened here. So they weren't blinded. They knew what they were giving. The medics knew what they were giving. They found that the ketamine group did much better. And why did they do much better? They did better because the ketamine group received on average 40 milligrams of ketamine, right? So they got 4 extra doses in the field. The paramedics were happy to keep pushing that ketamine. The morphine group only got on average 2 extra doses. So I think what we're seeing there is that, in the trauma setting, in these sort of I would argue the trauma case is another one where we're a little skittish about giving heavy doses of morphine, maybe incorrectly, but we are a little skittish. They come in, we start thinking maybe we should give them fentanyl, not morphine. It doesn't last as long. Maybe it doesn't drop blood pressure as much. And what we see here is the paramedics were feeling that too. When they knew they were giving ketamine, they were more willing to give more medication, and therefore the VAS dropped. The morphine, they were less willing to give as much medication, and therefore it didn't drop as much. So they only got 2 extra doses. So I think that, again, we're just seeing that the evidence is building that ketamine works as an analgesic. The side effects were relatively modest. We keep seeing that 8 or 9% dysphoria, not really emergence reaction here. It's more just they don't feel good. And that was evident, again, in the ketamine group here. So take it for what it's worth. So I think in summary of these couple sections, I would say that ketamine looks like a safe, probably effective medication for people who you have some relative or absolute contraindication to giving morphine for. And if you can swing it at your department, I certainly would advocate for it. And we do it at County all the time for trauma patients, all the time, especially when they're pelvic fracture kind of thing, and everybody's nervous about the morphine. Just an FYI of our practice there. All right, the next section is going to be about asthma and the bronchodilatory effects. Yes, sir?
So, do you have to deal with JFO and conscious sedation during this small dose?
So we, as a policy at our institution, we consider a dose of less than 0.25 per kilo not procedural sedation. They don't bother us. Now, have they, we just underwent a huge JACO review, and our hospital has other problems that attracted attention. So, like that the orthopedists were doing surgery in like a closet somewhere. So, unfortunately, I wish this wasn't being taped. That's a mistake. That's what they allegedly doing. Yeah. So we haven't had any pushback from that yet. It's certainly possible that could come back. And again, it's difficult. We all have to respond to the regulatory pressures that we're under, but so far we haven't had that kind of pushback. All right, so the next couple of abstracts I will breeze through because the message is, at the end is I think, relatively clear. So is ketamine useful in treating asthma? Okay, so the 9, 10, 11, and 12 are all observational studies of severe refractory asthma cases, generally for children, although one of them's for adults. No, actually, all these are for children. The adult one is in the next little section. All of them were given dissociative doses of ketamine. So in general, it was 2 milligrams per kilo. These kids came in, most of them received continuous nebulizers and then got 2 milligrams per kilogram of ketamine once the doctor deemed them to have failed. One of these studies, or 2 of them, are in the emergency department, another one's in the ICU, one of them's for ventilated kids. So these are pretty sick asthmatic children. All of them report beautiful results as a consequence. Everything gets better when you give the ketamine. The kids appear better, the doctors, stop sweating, all the kinds of things that you would like to have. So everything looks better, and some of the pulmonary function tests improve, etc. The problem with this is abstract number 13, I think. No, I'm sorry, 12. 13. And that is the lone randomized controlled trial of this. Okay, so this is efficacy of ketamine in pediatric emergency department patients who present with severe acute asthma. So this is right in our wheelhouse, ED patients. It's out of Baylor. And it's 68 kids, 33 got ketamine. They got it in a subdissociative dose in this case, right? So they got the 0.2 per kilo, not the 2 per kilo. And double-blind, placebo-controlled, really solid methods, unlike the previous 3 abstracts, which were basically case series. And what did they find? Nothing. It didn't do anything. It didn't do anything at all. So, that's unfortunate, right? We're all struggling when we have these really, really bad asthmatics, and we'd like to give them something, and people are pushing magnesium and all sorts of other homeopathic therapies that don't do anything. And ketamine would be a lovely adjunct if we had it. And if it was proven effective. And so we have 3 observational studies of high-dose ketamine that say it works, and then we have 1 RCT of the subdissociative dose that says it doesn't work. So I think the weight of the evidence is that subdissociative dose ketamine does not work. Okay? Now, it could be that we need to give dissociative doses of ketamine for these kids, or it could just be that when we apply dissociative doses in a better trial format, like a double-blind, then it won't work also. So I wish that I could, champion ketamine for the use of asthma. And as much as, I love ketamine, I do not use it for this indication. The story repeats itself for adults. So that's what numbers 14. 13 is just a summary of the literature on this, and it concludes the same thing that we just did because there's only 1 RCT. The preponderance of the evidence doesn't support it in children. In adults, we find the same thing. There's a couple of observational type things and case reports that suggest it's useful. 1 RCT done out of Highland in Oakland here that have the same problem. It just didn't do it. But it was also for subdissociative dose. So maybe we need an RCT of dissociative dose ketamine for severe refractory asthma, but nobody's working on that yet. That's going to be a hard sell to a lot of different places right now. So we're trying to build the evidence, and maybe some brave soul will undertake that project. But right now, I would say that the preponderance of the evidence does not support the use of ketamine for refractory asthma. All right. So the next couple of things, we only have 2 or 3 abstracts to get through. 16, 17, 18, I think. Maybe there's a 19. The first one is ketamine for RSI. Do any of you use ketamine for our rapid sequence intubation? So a lot of people. There was a big push a few years ago to sort of get rid of etomidate, or etomidate was coming under fire because of its association with adrenal suppression. It's not an association. Etomidate does cause adrenal suppression, and adrenal suppression is associated with worse mortality in trauma patients and septic patients. So there was some concern that etomidate might kill people who had those conditions. The big trial that emerged out of that was Ketased. That's number 16, where they looked at whether you could get good intubating conditions with ketamine versus etomidate in a randomized controlled manner, and whether mortality was different depending on whether you were intubated with ketamine and etomidate. The answers to those are yes, you can get good intubating conditions, and no, the mortality is not different. So the authors conclude that ketamine is a great induction agent. I think that's fair. I think that if you want to use 2 to 3, I think they use 2.5 milligrams per kilogram in this case, so a dissociative dose of ketamine to induce for RSI. You still need to paralyze with the usual paralytic agents like rock or sucks or whatever. But if you want to do that, there's evidence to support it. And this was a big trial set on nearly 700 patients of sick patients in European ICUs, et cetera. So I think that it's fair to use, but I think the authors could have just as easily concluded that etomidate's just as good. So if there's some particular reason you don't want to use etomidate, if there's some particular reason to use ketamine, people often ask me, well, what if I'm intubating someone for severe asthma? And I get it, there's no great evidence, but I want to do something, should I use ketamine? Personally, I use etomidate, and then I'll give them ketamine afterwards. I don't see any reason to induce them with ketamine. I use what I use, but if you want to use ketamine, I think that's fine. And you've had good experience using ketamine as an induction agent? Yeah, and that's consistent. I mean, they found good results as well. All right, the last two quick ones are, since we're going to start using ketamine for everything, we've got to know more and more about the side effects of it. So the two major side effects that come up over and over and over and over again in the literature are, number one, the one we talk about all the time, the emergence phenomena, or this dysphoric reaction, or whatever we want to call it. That's number one. And so number 17 is, can we stop that via some form of prophylaxis, right? So, and this is one of several randomized controlled trials that have looked at this issue. And what they ask, the question is very simple. If you pre-medicate with benzodiazepines, do you decrease the incidence of the emergence phenomena on the back end? This particular trial is negative. They found the emergence phenomena was 7% in the non-benzo group and 6% in the benzo group, and it was non-significant. Other trials have found significant declines. They're not included in this chapter. But in general, the number needed to treat is somewhere around 20. So you have to treat about 20 people with benzodiazepines. And again, this one's actually fully negative. So you'd have to treat everybody in the world with benzos to, prevent zero emergence reactions. But in general, I'd say it's probably around 20. And you have to decide for yourself, is it worth treating 20 people with benzodiazepines prophylactically in order to prevent one emergence reaction? Emergence reactions are generally easily treatable with benzos on the back end if they happen. And the other predominance of the evidence is that when you give benzos prophylactically, you add about 45 minutes of sedation time, right? 30 to 45 minutes, which ends up being a big deal because of all the regulatory problems associated with procedural sedation. The nurse has to stand there and sit there and check vital signs every 3 minutes until everything's better. So for my dollar, no benzodiazepines. I don't prophylax with it. I let them have an emergent, the 1 in 20% or 7% or so that has an emergence reaction, I just treat those ones and move on. So that's what I do there. The last piece is ketamine-associated vomiting. This is much more common than the emergence reaction. It probably happens in 15-20% of people with ketamine, and it even happens after they leave the emergency department. They're nauseated and puke when they get home. So this is a randomized trial, let's look at 19, effective on dansitron. So this is Zofran to reduce the incidence of vomiting post-ketamine. And what they found in this case was that the control group, 12.6% had vomiting, only 4.7% or 5% in the ones getting Zofran. This is another one that's relatively consistent in the literature where the number needed to treat is around 10. So you got to give 10 kids Zofran in order to prevent one kid getting vomiting. Some people would say, it's up to you to decide whether that calculus works in your favor. I tend to pre-treat with antiemetics personally because it doesn't add any time on the back end. And then the other issue is that those proportions are only for in the ED vomiting. Once the kids go home, there's still a high chance of vomiting. It actually increases to about 30% and 15%. So, and then the Zofran reduces the 30% down to 15. So for my money, I give the kids I generally, if I remember, give the kids a pre-treatment with Zofran, and then and live with it. But I don't for benzodiazepines. So thank you very much. In summary, oh sorry, yeah.
So you give the Zofran before the ketamine?
Yeah, it's a pre-medication. 20 minutes, something like that. I often forget, I'll be honest, because it's not on our procedural sedation checklist, and I wouldn't say that it has to be or it should be part of your hospital protocol or anything like that, but that's what we do. When we're getting it sort of set up, I say, oh, give the kid Zofran, either IV or just an oral dissolving tablet. Yes?
So there, in one of the studies earlier on about allergies, it was talking about using IM, only IV, but it might, is it?
So most of the studies have used it IV. There is like the New Mexico study, some proportion, I think it was about 20% or 15% of them got it IM. There's no reason, I mean, it's highly bioavailable through an IM route, so there's no particular reason not to use it IM if that's the case. And you know, if you had like an injection drug user or something like that you couldn't get IVs, and I think that might be reasonable.
Easy to get through.
Yeah, that's a great point. That's a great point. It tends to trigger less scrutiny when it's an IM dose. Great point.